A topic continues to be a major contributor to mortality and morbidity worldwide, and one that demands timely intervention and precise clinical decision making: coronary artery disease. We begin with our first presentation, STEMI in Peripheral Practice, Missed Minutes, Lost Myocardium, by Dr. Gotabe Ranasinghe, Senior Consultant, Interventional Cardiologist. Sir, the stage is yours.
Yeah, first, good morning. First of all, I must thank SSCC, the President, Dr. Asanka Durmila, and the entire team for inviting me for this lecture. And we all know that STEMI is a challenging condition, and especially in peripheral practice. And we in STEMI, we know that the thrombus is the real challenge. And but in peripheral practice, it's not the thrombus, it's the delay is the real challenge. So let's see how we handle that. So this is the outline of my lecture actually. So first I go through all these things, the introduction. So diagnosis, triage, acute management, revascularization, and then treatment strategies. The current practice in Sri Lanka, so I think we should know. And finishing with conclusions. So as I told you, ST segment elevation infarction, so STEMI remains the leading cause of morbidity and mortality in Sri Lanka. And Sri Lankan healthcare system faces significant challenge to provide optimal care to patients with limited and absence of PCI capable centers, especially in peripheral areas. So the ACS, this belongs to ACS, is a spectrum. You know that the unstable angina, non-STEMI and STEMI. So with in the spectrum, so the major portion is the STEMI. And so they come with either cardiac arrest, or can be silent, it can be syncopal attacks, and can be malignant arrhythmias, and can be with typical symptoms with classical ECG changes. And so this is the way the STEMI comes, and the most important thing is the symptoms. So a local scenario, so this is according to Sri Lanka STEMI Forum and the Ministry of Health statistics. We have about 63,000 patients island-wide yearly. And so this is actually the AMI. The ministry doesn't have STEMI and non-STEMI, but majority here is actually non-STEMI. And 5,000 per month. And the 175 to 200 cases daily. So this is the number of AMI, especially in the Western province, according to Sri Lanka STEMI registry. This is conducted by Sri Lanka STEMI Forum. And so this is, you see over the years, 2017 to 2022, the rise of numbers, and it's an exponential rise. We are in the middle of real epidemic of acute coronary syndrome, mainly the STEMI. So the diagnostic tools, the diagnosis is the most important thing in if you suspect STEMI, and because of management we have to do very early. So according to ACC/AHA guidelines for STEMI, the most important thing is actually ECG. We have to do first 10 minutes when the patient comes with STEMI. And so if you suspect STEMI, so you have to do the ECG within first 10 minutes. And also, so then why? Because you have to direct the patients after first medical contacts whether to go for primary PCI or thrombolytic therapy. That's why it's very important to do the ECG first, at least from the first medical contact within 10 minutes. So there are many ECG changes actually. The classic one is in STEMI, the ST elevation. One should know exactly how to diagnose, how to see, how to detect the classical ST elevation. There are other variations like pericarditis and even the bundle branch block patterns. And by the way, and the new onset of left bundle and right bundle with classical symptoms also you have to suspect STEMI. And so that's important because a lot of people miss this. But when you see a bundle branch block, with classical symptoms, always ask the all ECG if they have. If they don't have all ECGs and symptoms of classical, take it as a STEMI. And so the classical ECG changes, you can see the first diagram, and the STEMI classical ST elevation you see in various leads depending on the type of MI. And sometimes you don't see that. You see hyperacute T waves, very tall T waves. Here you have to diagnose if the symptoms are very suggestive. And there's another thing called De Winter T waves. That's a De Winter phenomenon. And you see there's a peaked T, before that there's ST depressions. And also the hidden one, posterior STEMI, you might not see ST elevation here. The obvious to your naked eye, you might see ST depression, especially V1, V2, and peak R, but you have to do special leads and V7 to V8, V9 to see ST elevations. And so those are the main ECG changes of STEMI. And also the other biomarkers, of course you don't need the other biomarkers for diagnosis of STEMI. What you need is actually classical symptoms and the ECG changes. But anyway, high sensitivity cardiac troponin is also recommended in all patients with suspected ACS, but STEMI, I would say you don't need that unless the diagnosis is in doubt, and then you do serial troponins. And so according to guidelines also, and so if patients suspected of ACS, troponin should be measured as soon as possible, and so using high sensitivity assays. And if you have any doubt, of course, not in case of STEMI, but in other non-STEMI especially, and you have to repeat it and after 1 to 2 hours according to guidelines. But again, I'm highlighting in STEMI, you don't wait for troponin, you don't need that. Then initial measures, when somebody comes with STEMI, initial measures, and when they come with to emergency department, your OPD, wherever, actually we overall, we have to think about pre-hospital logistic care, and then the ambulance service, and then the emergency department facilities, all that. And then time to treatment is very important in STEMI treatment. And also overall, the healthcare system and system delays we have to consider, because the time is the most precious thing here. Every minute, and you compromise your the myocardium and then increase the mortality. And so emergency medical services also very important in that case, whether it's ambulance, whether it's emergency department, very important. You have to have very good coordination. And more than anything else, all together, doctors, emergency services, and hospitals, we have to have organization of STEMI treatment networks. Network is the key. So as I highlighted, the system time goals of STEMI. So you see, as I told you, first medical contact to ECG. When the patient comes, you have to do that within 10 minutes ECG. And so then if you think that this is a case of the primary PCI, and then immediately you have to send the patient for primary PCI. And so that delay should be at least, you have to do it within, if it is a PCI capable hospital, within first 1 hour, 60 minutes, or otherwise it's a non-PCI capable hospital, is 90 minutes. And if you have decided to thrombolytic therapy, that means from the time the patient comes to you, and within next 2 hours, if you can't get the primary PCI, then you decide immediately within next 10 minutes at least. Now they say according to latest guideline, here it says 30 minutes, and that was earlier. And so you have to think of thrombolytic therapy. So this is how the STEMI system works. And so when you have STEMI patients, of course you have various ways to inform the hospitals from the ambulance itself, and then within the ambulance also the emergency care system. So you diagnose and then triage these patients and decide on transfer, whether to non-PCI capable hospital or the PCI capable hospital. All depends. And if it is ambulance, you decide depending on the close proximity. And so you should not wait more than 2 hours to decide the type of treatment. If you think that if the patient from the first medical contact, the delay would be more than 2 hours, of course, immediately you have to decide on thrombolytic treatment and then transfer. I will explain those things later. So then acute management, of course, initial diagnosis is very important, then monitoring. So then we do normal conventional therapy, so oxygen, nitrates, pain reliefs, beta blockers, then the dual loading doses. I will tell you later on the types. And so aspirin and P2Y12 inhibitors, all that normal conventional treatments. Of course, oxygen, I have to highlight that according to the latest guidelines, in patient with STEMI, and if the saturation is less than 90%, and then you give oxygen. And if it is more than 90%, you don't give oxygen, that will harm. And because everyone, we have a tendency when somebody comes, especially with STEMI with severe chest pain, we tend to give oxygen. So that might harm. So you always check the saturation. And the time is the myocardium here, because every minute delay, you compromise the blood flow and the infarct size and the outcome. So this is a beautiful study. The systemic review of randomized and non-randomized trials compared the reperfusion strategies on non-PCI capable hospital. That showed the earlier reperfusion dramatically reduced the infarct size, and the early treatment produces the greatest mortality benefit. Even late reperfusion may improve survival even if the myocardial salvage is small. So you can see very clearly here, early the better. You can save a lot of myocardium, and the reduction of mortality benefit is very much more. And every 30-minute delay, you can see the relative risk of 1 year mortality goes by 7%, 7 to 8%. So it's the most important thing is the timing. And this chart, you can see the selection of the pathways. And so from the first medical contact, from the symptom onset, you decide. And so patient can come on their own, or patient comes in an ambulance. And so first medical contact, the patient suppose comes to a PCI center. And so then no worries, within next 60 minutes you have to arrange the PCI. So suppose patient comes place like Gampa, and so non-PCI center. Of course, then you decide whether you should be able to transfer this patient to Colombo National Hospital or Ragama, North Colombo. And within next at least 2 hours, 120 minutes. And if not, please start the thrombolytic therapy. And if you can get the patient within 90 minutes to the particular cath lab, that is the key. And so there are several ways of reperfusion in the STEMI. So first, most in this part of the country, I think we still go for fibrinolysis or thrombolysis. And this is a very important strategy, and still in this country we do this. Successful reperfusion is generally associated with significant improvement in ischemic symptoms and ST segment the reduction. And hemodynamic stability. You know the basic physiology, so you know the coagulation. We get the thrombus with thrombin formation end of the day, and we have to dissolve the clot with plasminogen activator. So that's where the thrombolytic treatment comes into play. And the clinical benefit of thrombolytic therapy, of course, we all know that early thrombolytic therapy in STEMI reduces the 30-day mortality at least by 18%. Thrombolytic therapy itself. So this study, you can see in this chart, and within first 12 hours of symptom onset, there is significant benefit of mortality, morbidity, and ischemic complications when we give thrombolytic therapy. Still you can use in your practice. And the different thrombolytic agents, first generation, second generation, third generation, very basic, but I wanted this slide for you to remember where the streptokinase lies. It's a first generation. 20 to 30 years ago, we practiced this. But in this country, still some people are promoting, some doctors prefer to use. But remember that it's a first generation thrombolytic agent. It's no more in other countries for STEMI. But here, I strongly believe that we should go for third generation. That is tenecteplase. And so that's you have to remember. And comparison of streptokinase again with other thrombolytic agent, you can see, and this study shows that large scale trial indicate that accelerator TPA given with intravenous heparin provides survival benefit over previous standard thrombolytic regimes. Compared to streptokinase, you can see the survival benefits as well as the patency rate, in improvement in the patency rate. So there's no question, and other thrombolytic agents compared to streptokinase, they are better. And here you can see, and this particular analysis is very clearly shows that the 90 minutes patency rate after giving thrombolytic therapy with comparing streptokinase, altiplase, tenecteplase, retiplase, they again altiplase and tenecteplase, you see the 80%, 80 to 90% patency rate. So that's far better than thrombolytic, the streptokinase. And then the primary PCI. Primary PCI can be defined as reperfusion by means of coronary angioplasty or stenting in acute STEMI without prior administration of thrombolytic therapies. And the primary PCI is the gold standard. That's the number one. It's not the thrombolytic therapy. Again, I highlight the fact that is the number one treatment for STEMI treatment. According to these the latest guidelines and ACC and ESC, and they recommend PCI the initial approach and to manage STEMI. So it very clearly says these guidelines, the STEMI has to be, the primary PCI should be the first line treatment for STEMI. And so you can see that the right coronary artery is occluded, and then with the primary PCI you get normal flow. And so which one is better, thrombolysis versus primary PCI? This is a famous meta-analysis, 23 trials published in Lancet 2003. So it shows very clearly that primary PCI is better than thrombolysis when it comes to morbidities as well as ischemic complications. And so there's another type, pharmacoinvasive. I think this part of the country, I think this is very important. This is coronary angiogram. You do the coronary angiogram after successful thrombolysis. And so you usually perform between 2 to 24 hours after successful thrombolysis. And when timely, if it is done within timely manner, I think this is the best. And also the equal benefit compared to primary PCI. So it provides the same comparable benefit if you do it in a timely manner. I will explain it later. So this is the pharmacoinvasive strategy with improved myocardial reperfusion compared to delayed primary PCI. So this is a prospective multicenter randomized trial, and here is very clearly shows very early the fibrinolysis, and within 3 hours of symptom onset, and improved myocardial reperfusion and reduced ischemic complication compared to delayed PCI. So if the patient comes with 6 hours of symptom onset, and if you can catch the patient within first hour from the first medical contact, if you think that you can't get the primary PCI, give the thrombolytic treatment, and they send the patient to the PCI capable center for angiogram within first 3 to 4 hours. Don't delay it. If you delay it again after successful thrombolysis, benefit is not there. This is the study, and I'll explain it later. So this again pharmacoinvasive, you can see that tenecteplase given, and you see the still the flow is there, but successful, but there is a stenosis. So you have to do the pharmacoinvasive treatment to get the full benefit. Then, and also I have to tell you about the pharmacoinvasive strategies. You have to do the angiogram at least within first 3 hours of the successful thrombolysis. If you don't do it, and if you delay it, and so again the benefit, you lose the benefit. So it has to be early. And so there are other areas of treatment of non-STEMI. So indication for rescue PCI, that's where the fibrinolysis or thrombolysis not working, and there is no improvement of ST segment reduction. And if it is not coming down more than 50% of the original within 60 to 90 minutes, then in that case it's fail. And these people can have chest pain, and also ECG changes and can be arrhythmias and hemodynamic instability. So those patients should be immediately transferred for coronary angiogram and PCI. Yeah, then antithrombotic therapy. Antithrombotic therapy, mainly antiplatelet therapy. So it's a cornerstone of STEMI care. Why? Because we know that thrombus is formed with platelet. So we have to break the thrombus, and so that's why it's a very important part of the treatment of STEMI antithrombotic treatment. So determinants of antithrombotic treatments. So see the patient characteristics, very important. The age, sex, and the previous ischemia, all matters, and then clinical presentation, whether it's a non-STEMI or STEMI, or all that important, and other comorbid conditions, whether a patient is diabetic, heart failure, CKD, or other comorbid conditions, very important. Co-medications, and so also important, and whether the patient is on anticoagulant, for example, and the procedural aspects. Whether the patient is going for PCI or CABG, or the femoral approach or radial approach, all important. So antithrombotic treatments, the choice of drugs, dosing, treatment duration, everything is important depending on these circumstances. And so all depend on the ischemic risk and the bleeding risk. You have to weigh it, you have to navigate in between and see the best antithrombotic treatment for the patient. And so this is a trial. Actually, this trial based on Plato and the Triton Timid 38. So you see the DAPT with the clopidogrel and comparing ticagrelor and even prasugrel. Is very much they are better in STEMI treatment compared to clopidogrel. So we still practice clopidogrel, but remember that in STEMI situation, the most important drugs are not clopidogrel, is either ticagrelor or prasugrel. And so again, this study, the ISA React 5 trial, demonstrated that treatment with prasugrel versus ticagrelor in STEMI significantly reduced the composite rate of death, MI, stroke, without any increase of bleeding complication. Here also in STEMI situation, whether it's a prasugrel or the ticagrelor, I would say still if it is STEMI, it's ticagrelor. But the study shows it's ticagrelor, the prasugrel, but that is driven mainly by the non-STEMI patient. In case of non-STEMI, one has to think of actually when the coronary angiogram is done, anatomy is known, then think of prasugrel. Otherwise, is still the ticagrelor. So this summary, antiplatelet drug selections according to the latest guideline, and you see the PCI patient in STEMI. So aspirin plus ticagrelor or prasugrel. There is no difference between two. The aspirin plus ticagrelor, prasugrel in STEMI situation. If the patient is going for bypass, then aspirin or again ticagrelor, clopidogrel, and continue aspirin during CABG and stop the P2I12 and restart when then the patient is, if you think that the time after safest time after post-operative after CABG. And no planned invasive evaluation, that's kind of medical treatment. And so then aspirin and ticagrelor is the best option. If the patient is not responding to or allergic to ticagrelor, of course, then clopidogrel can be used. And so this is another important thing. After thrombolysis, they are usually aspirin and clopidogrel. You don't give strong P2I12 inhibitor unless this patient has some problem with clopidogrel. So this other thing is anticoagulant selection according to the guidelines. Remember that in case of STEMI, at the time of primary PCI, unfractionated heparin is the choice, and patient who has had thrombolytic therapy and so planning for pharmacoinvasive later on or even medical treatment, the low molecular heparin is the best option. And so that difference you have to understand. This is what these guidelines mention about. So then the current practice in Sri Lanka, one has to understand the current situation. And so we all know that, as I highlight, the choice of reperfusion therapy depend on hospital capabilities, geographic proximity to skilled PCI facilities, the time between symptom onset and the presentation, that's very important, and the patient risk profile, all that important. And so then if you do it, timely reperfusion, reduce the infarct size, minimize the myocardial damage, and preserve the left ventricular function. That is the most important determinant of the mortality and the reduced morbidity and mortality. And so what if PCI is not achieved? This is the study in a timely manner. So you can see that if it's not done, approximately and 8% of excess mortality for every 30 minutes, as I highlighted before. So there is a mortality increase with time. So that's why you have to do the reperfusion, either PCI or if at all thrombolytic therapy in a timely manner. And so major barriers for timely reperfusion we all have come across in this part of the, not here, even in the tertiary care hospital, limited PCI capable hospitals, and geographic challenges for rapid transfer, the traffic, etc. And inter-hospital transfer delays with various logistical delays. We all know that what the causes these delays are. And so we have introduced this wagon wheel model for STEMI care to prevent this delay. This is proposed by Sri Lanka STEMI Forum and Sri Lanka Heart Association, and now it's College of Cardiology. A protocol specifying the reperfusion strategy based on geographical location of the patients, the patient's first medical contact, and the regional availability of the PCI services to achieve better adherence to guideline recommendation and improve the mortality. So this is the wagon wheel model we have introduced, and so you can see that there are several levels, and in the middle you see the hub. That's where the cath lab is. So depending on the level 1, 2, 3, 4, even going up to 4, and so you decide on the type of treatment. If it is a level 1, of course it's a hub, primary PCI. Level 2, transfer for primary PCI, if at all within 2 hours. And so level 3, periphery, and so you use the pharmacoinvasive. So this is another elaboration. Now this is the current situation. You can see all the provinces except Abaragamo and Uva. Now we have got cath lab. So very easy to operate this system. And so level 1, level 2, level 3 you can see. And so teaching hospital all map. And so then you can decide on which hospital you should transfer. You all are lucky in a way because you have now Colombo North as well as National Hospital Colombo. Both hospitals you have. And so this is the real map in Western Province. I have mapped it. You can see even the distance. Now see the Gampaha, and so 36 kilometers. And so it's not that far. And to the nearest the National Hospital Colombo. Of course, now when it comes to North Colombo, now it's shorter. So this is a quality evaluation of AMI care in Sri Lanka, and this highlights the needs for improved referral pathway for stronger PCI center network. So this study actually the 934 patients, 90% of them are actually were STEMI patients. And so we analyze these patients in this STEMI registry patients in the Western Province. STEMI care quality in Sri Lanka is suboptimal, and particularly at the system and organizations level, hospital as well as network level, despite good use of medical therapies. We have good medical therapies, but system is chaotic. The gap in STEMI care is not pharmacology, it is timing and system. Only 10% of our patients achieve more than 50% of quality compliance. So this is the study we published in BMJ in 2020 and British Medical Journal. You can read and see the real problems. And so another study, door to balloon time, again published in BMJ Open, and so that also shows the medium door to balloon time, even in tertiary care hospitals, 110 minutes. We are trying to achieve 60 minutes. So in our setting, delays beyond 120 minutes significantly increase the hospital mortality. And with old age and the female sex identified as the independent predictors. So this highlights the critical importance of timely reperfusion. There is no question. We have analyzed. We know that there is a delay. So this study we published in VMJs highlight that very well. And so there is another weighting and publications, of course, trends and outcome of STEMI care in Sri Lanka against the patients, now 5,000 odd patients, and we have analyzed. According to this, you see the conclusion. Overall in-hospital mortality declined from few years ago, from 2020 up to now. So you can see the 6.5 in-hospital mortality now is about 2%. So because we use the wagon wheel model to a certain extent, and not all the provinces, especially in the western province. So there is a significant improvement in the mortality, STEMI mortality. And improvement in pre-hospital triage and coordinated STEMI care network may have contributed for this significant benefit. This highlights the need for continued investment in timely perfusion, reperfusion, and chronic disease management like diabetes and hypertension and other issues. So this is again what we have done. What we have used, STEMI, the wagon wheel model, we see the benefit now. So in conclusion, I want to highlight that STEMI, one of the biggest killers in Sri Lanka still. So the mortality rate is still though we have shown in hospital mortality is about 6%, and what is very comparable to Western countries. We should be very proud of that, especially after introduction of wagon wheel model, but still in other areas, and it's not that great. The primary PCI should be the gold standard of STEMI care treatment, and it should be considered at least for all high-risk patients with from the first medical contact within 120 minutes. That's the must. The tenecteplase is the preferred thrombolytic agent of streptokinase. I encourage the usage. Don't ever promote streptokinase. Don't ever even think of giving streptokinase to STEMI patients. If the primary PCI cannot be delivered within 120 minutes, a well-executed pharmacoinvasive strategy achieves outcome comparable to similar to primary PCI. Don't get disheartened if you can't get the cath lab. If they are busy, don't trouble them so much, and then get the patient within first hour of the medical contact, and so then start the thrombolytic therapy and send the patient for angiogram early, within at least first 3 hours. Don't delay it. If you delay it, you lose the benefit. And building a dedicated STEMI care system, the provincial and national level, is a must in order to achieve more, save more lives. And therefore, the wagon wheel model is the currently practiced cost-effective model used in Sri Lanka. So we have to encourage it, we have to use it, and to prevent, improve the mortality and prevent additional deaths. Thank you very much.